All right, good morning, everyone. Welcome to those in the room and those online. I am very pleased to welcome today's speaker, Dr. Ken Resnicow, who is a professor in the Division of Epidemiology and Community Health in our School of Public Health here at the university. He joins us after a long time at the University of Michigan, and we are very excited to have him here. Dr. Resnicow has expertise in health behavior and health equity with over 35 years experience designing and evaluating behavior change programs on topics ranging from smoking cessation to cancer screening and genetic testing, among other topics. And today we are excited to hear his reflections on more than 10 years as Associate Director for Community Outreach and Education at the University of Michigan Cancer Center. Welcome.
Thanks, Dawn. It's a pleasure to be here. Thanks for coming out. I want to share with you some of the things we did at our COE program. And my ulterior motive is to increase collaboration for myself here. And so some of the things I decided to highlight are things that I think might have potential, or you already are doing a version of it here at the Masonic. So I was the first AD of COE in 17 when it became a thing. And for the 17 years before that, I was head of health disparities and community engagement before there was such a thing as AD for COE. All right, the page down doesn't want to work. Okay, so this was the team when I left. So it's mid-size. I'm on a couple of EABs, so I kind of can compare it to what other people are doing. So this was our staff before we left. And since then, they replaced me with Lynn Henry a couple months ago. She's doing a great job. And the administrative director, Noel, retired, and that position is still open. In terms of financial support, it is certainly on the increase, almost doubling since 21. And it's a little hard to see, but that's mostly staff is the green bar that increased more than the other domains. It's cut off on the bottom, I'm not sure why. One of the things that will become clear is the aims and tasks of COE are very similar across the country. So these could be the aims for almost every COE program in the US, but I'll just try and highlight some of the subtle ways ours was a little bit different and unique. So first of all, like every COE program, we spend a fair bit of time characterizing the cancer and risk factor rates in our catchment area. Our catchment area is the entire state of Michigan. That was a change. That only became true in 21. Before that, it was Southeast Michigan. Like you guys who have Mayo, we also have another comprehensive cancer center, Karmanos. And Karmanos also went full state. So we have 2 comprehensive cancer centers that serve the entire state of Michigan, not unlike what you guys have with Mayo. And the first 2 sources of data is what everyone uses. The slight novelty is we also did a supplemental survey multiple times to get additional risk factor and incidence mortality data. And this is what everyone produces. This is our county level incidence and mortality. And this is the main slide that when we talk about COE and the cancer priorities, the risk factors priorities, this is the digestion of all that data. This is where it lands. We are the 13th highest cancer mortality in the country. These are our 9, let's see, there we go. These are our 9 priority cancers. And in some cases like myeloma, there's not a lot of activity. So it's one of our stretch goals. It's one of our future priorities. Now, just to be clear, the University of Minnesota has a wonderful equivalent report. Jen Pointer sent me this, so it's a little small up there, but it's basically a beautiful representation of the same analyses that have been done at the Masonic, and just about every cancer center does. This is the one that has racial disparities, probably too small for you to read. So I just want to tell you a few ways our characterization is nuanced. So first of all, our program leaders and our director asked us to create a speaker's kit. So we, every year, circulate an annotated speaker's kit that they can use. And it's going to be a lot of the slides you see here, except there's a notes field that tells them where we got the data and some comments about it. They also asked us to indicate trends. So we have a little up hat and down hat on all of our slides. You'll see one in a few minutes indicating that this incidence, mortality, or risk factor prevalence is going up or down. And we also highlight areas where we're different than the US national data. As I mentioned briefly, and I'll show you some more detailed data, we had 3 supplemental surveys. Because we have the largest Arab American community in the United States, it's tied in numbers with California, but ours is more concentrated. Folks live in a very tight area, sometimes called their Dearborn Enclave. We surveyed twice about 400 to 500 MENA residents to understand their health risks, and I'll show you some data from that. And then we did a consumer rating study twice, and that's something I strongly encourage you to consider, where we asked members of our catchment area how they felt about the University of Michigan Rogel Cancer Center. We asked things about parking, we asked things about how polite people are, but more importantly, we asked them about who's concerned about your community, who does cancer outreach activities, and they got to look at all the healthcare facilities. I'll show you the item in a few minutes. And we had some really nice changes. It went a long way at our site visit because there was some concern that we weren't bonding with our community. This consumer survey, you can get gold out of it. So it's one of my take-home messages for you. And finally, we asked people who had attended prior events or people who had signed up for the Health Registry about what cancer priorities did they want us to address for the next 2 years. And that shaped the activities that we undertook. So here's an example of the up hats of these are things that are increasing since the last time we looked. We updated this about every year. Sometimes there's a delay in NCI, so once in a while we skipped a year. This is the race data, US versus Michigan, and everything that's in yellow, Michigan is worse than the US. There are a few things, particularly in the risk factor domain, where Michigan is better. A lot of that is due to the fact that Michigan was a Medicaid adoption state. We have something called Healthy Michigan, and that ends up driving a lot of these parameters, why Michigan is better than the US overall because of Medicaid expansion. And this is just some examples of Burfus data where there's differences between Michigan by race and the US. So just a note about the MENA community. We had seen some data that suggested this, but it was very small sample size. So we wanted to go out and get more stable estimates. And what you can see here is pretty strong decrements in cancer screening in the MENA adults in the Dearborn Enclave. Whoop, it's got some timer on it. So you could see 40% lower for colorectal and significantly lower for mammogram and pap smear. It's complicated why. There's modesty rules if they're observant Muslims, and even the Chaldean Christians also have some modesty issues about being alone with a provider. They need a relative or their husband there. And then some folks didn't want a physician from their community because they didn't want the word to get out. So there was both a desire by some people to not be treated by someone they knew, and also for some religiously to require someone they knew in the room with them. Just a quick note about the consumer survey. So we did it twice. We had plans right before I left to do a third time. I don't know if Eric, who's our director, will do it, but I hope he does. We hired an outside firm, Harris Polling, which is based in New York. So they did the very sort of high-end Cadillac random digit dial, including both landlines and cell phones. And here are a couple of the questions that are taken from the CADI survey, so from the orally dictated items over the phone. So I just want to highlight, here's one of the following healthcare systems, which you'd be most likely to go if a loved one or needed treatment for cancer. Which of these institutions is most committed to serving your community? If you had to ask one item, I would ask that. So if you could show that you're improving in that, site visit members really took to that, and it gave us some street cred. And then the third I'm going to just have there, which is the best at doing cancer research. Now, just so you could guess, the healthcare systems changed a lot between 2011 and 2019. Michigan took over 4 different healthcare systems, mid-Michigan, Western Michigan. So we had to change the list, but nonetheless, the main players carried over from 11-19 and would also be true today if we did it in 25 or 26. So I'm going to show you 2 findings that, again, the site visit team recognized and I think helped us get our pretty good score. So this is the question: who's most committed to serving your community? In 2011, there was a pretty big black-white difference of about 7 points. But by 2019, I'm not taking entire credit for this. A lot of other factors went into this. But by 2019, African Americans actually rated Michigan as the top 30 versus 22. Another item I'll share with you is who's the best at treating cancer. And in 2011, again, there was a pretty strong black-white decrement. But by 2019, there was basically parity. Okay, suggesting that there's some positive marketing efforts or some positive awareness of what U of M Rogel can do. I was torn whether or not to go into this in much detail, but these are just the main critiques from the most recent site visit. This is our most recent renewal in 22. And then the last EAB where I was still running the show from 23. And these are the same criticisms that I see in other cancer centers. So just like the catchment data gathering and characterization seems to be somewhat common, I think the criticisms of COE programs, there's some common denominators across the country. And this is our top level response. I'll go into a few of these in more detail, but we did intensify our MENA activities, particularly in the intervention domain. We implemented more evidence-based interventions, and we increased our staff by 4 people. That's why it jumped over $1 million. So one of the big topics is this idea of bidirectionality. So there's multiple entities where there has to be bidirectionality. So it's COE with your CAB, COE with your program leaders, COE with your communities. I'm just going to highlight 4 examples of collaborative interactions of COE with either CAB programs or community. I mentioned this survey. This is the one that we asked people who had attended events and or who had signed up for our health registry, which is a promise or an interest in participating in research, even though they have not, and they were not necessarily patients. And we had 111 responses. And this is what they said are their priorities. This priority of genetic testing led us in part to this UO1. So this was a moonshot grant that is just about over with, that had 2 primary aims. First, to improve across the statewide collaborative of oncology practices called MOXIE, to improve the rate of family history ascertainment with a digital tool that Elena Stoffel created, who's a GI doc and a geneticist. And the part that I helped develop was a randomized intervention trial. People who were identified electronically from the family history tool, who are eligible based on NCCN guidelines for genetic testing, they were handed over to me, and we randomized them to 3 arms: usual care, a purely eHealth digital navigator, and then motivational interviewing by genetic health coaches. Ooh, I don't know if the sound's going to work. I don't know if I clicked on it. So the digital arm include tailored videos. So we did some calibration work right when we got the grant, and we identified the top 10 or 12 barriers to genetic testing and the top 5 or 8 drivers to the benefits of genetic testing. And we built customized video clips that when the individual logged onto the website, the clips that appeared were based upon their baseline barriers and drivers. In the genetics coaching arm, we didn't actually use genetic counselors. So there was a long history of why we made that decision, but there's this general shortage of genetic counselors. So we've tried to fill that gap with genetic coaches, where people who had less than a master's degree in genetic counseling. And then we train them in a new model of motivational interviewing, which again is probably too small for you to see, but it makes a very strong distinction between equipoise genetic testing, it's up to you, versus recommended genetic testing because it's medically beneficial. And we train these coaches whether or not it was an equipoise genetic test we're talking about, or whether or not we're talking about a persuasive genetic test. And we publish that in the Journal of Genetic Counseling. So it's my bad. I hope this will work. Can I? Ooh. All right, well, you'll have to take it on faith that there's a tailored video clip here that is addressing this barrier that they checked on their baseline questionnaire. And again, the website tailored the selection of video clips that this person saw, the ones that were corresponding to their barriers and their drivers. I'm sorry, because if I turn on this, it's not worth the audio tumult. So that study was our best example for our site visit of large impacts. So we had almost 18,000 family histories done across the state. We just completed a week ago our final one-year follow-up. And we're pleased, although I'm not going to share the exact odds ratios at the request of the MPIs, but we have a pretty strong effect of doubling or tripling the odds of self-reported genetic testing in both intervention arms. Since we got the original U01, we've done an African-American sub-study. We have a K awardee who's just studying genetic testing barriers in African-Americans. We have a MENA sub-study where we interviewed half an Arabic members of that Dearborn enclave about their views toward genetic testing. And then we have 2 cascade studies, one with African-Americans, one with the general population. And finally, we've started to develop an AI-based counselor. So instead of us pre-designing messages, which is called rules-based tailoring, we're now relying on ChatGPT to generate the genetic counseling, and it's doing a very good job. Just a note, I mentioned this already, but I'm going to share a little results about our MENA work. The US has probably 4 million. They're undercounted because historically MENA was not a drop-down ethnicity. People had to write in generally under white, or they could have written it under black. But because of that, most people agree that it's probably 40 to 60% underestimated by the US Census. The Michigan MENA community is unique in a few ways. It has a much higher rate of Iraqi, Assyrian, Chaldean Christian than the rest of the country. That's one of the main differences. So this is the MENA Health Survey. My Arabic sucks, so I can only tell you this is the alcohol item. And we were able to get about 25 papers out about barriers to screening. I showed you that data, 30 to 60% lower screening rates for the the big 3 cancers. But we also wrote with a couple of scholars an essay about Arab identity and the importance of the Census Bureau and NIH to recognize MENA as an ethnicity. And we're not taking any credit, although Matt Stifler, who was the co-author of this has been his life's work. It changed. So under the Biden administration, they made a formal adoption that now Middle Eastern, North African in the upcoming census, and even before 2030 in some NIH and DHHS documents, you now have a predefined pull down. This is going to have tremendous benefit for the MENA community because it's going to double the population probably, which entitles them to some additional funding, and hopefully it will allow, and this is very tricky, NIMHD, I was on their council for 5 years, so I'm sort of privy to what happens. They decide what's a minority, and they decide what's a priority minority group. They haven't done that yet, but they're in the process of identifying MENA as a minority and a health disparities population. When that happens, then across DHHS, there can be RFAs for the MENA community. So they still can't do it yet, but once they designate them as a minority group and a disparity group, those are 2 separate phenomenon, then they can start to include them in disparity-related RFAs, which is it's not a great time for those right now, but maybe in the next administration. So one of the things we did that is very interesting. Kola Okanyeme, who's on your EAB and is a dear colleague, he was here, then he went to Utah, now he's at Indiana. He did one here as well. So we created an Arabic-based smoking cessation program linked to Ramadan. So basically, we marketed it on Eid, the last day of Ramadan. We said, for the last 30 days, you haven't smoked from sunup to sundown. Why not make it 31 days? Why not make it 32 days? So keep your streak going. And that's what the Yalla Quit program was. So we had trained counselors who were bilingual in English and Arabic, who knew motivational interviewing, who were available to counsel folks to quit smoking. So it's really goofy. Ramadan with smoking. It is not the wittiest thing we ever came up with. We did it in collaboration with a MENA-based FQHC called Access, and they were our co-sponsor. So just some of the promotional materials. So one of the things we looked at, this is not a cancer issue per se, but we felt it was important, is we measured deportation worry, and we also measured their anxiety and depression with the PHQ-4. So I'll just show you what we found. So this is the question here in English. This is the Arabic version of it. Do you know or do you worry that a family member will be deported? Then these are items that all of us use. The first two are the depression subscale of the PHQ-4, and the second two are the anxiety subscale of the PHQ-4. And not surprising, there was a pretty strong effect that folks who had any deportation worry, as well as people who said they are the victims of discrimination, they had much higher estimates on the PHQ. In this case, this is the PHQ-4, combining the two anxiety and the two depression items. And we have a couple of papers still in press, particularly interviews with MENA members about their barriers to genetic testing. So one of them is very interesting. It may seem very old-fashioned, but there was a concern if we get genetic testing with our daughters and there's a positive pathologic variant observed, her marriageability is declines. Her value in the marketplace, so to speak, is less. So there is a hesitance because of sort of the matchmaking culture to not want to know the answer. So some of the other things we're doing in the MENA community, we've been sponsoring, there's an Arab Health Summit that occurs every year. We're gonna have the next one in April in Tunisia. And so we co-sponsored it in the $25,000 to $50,000 range. And we also had multiple speakers and workshops on motivational interviewing and on e-health message design. So we've done it in Turkey, we've done it in Morocco, and we're doing it in Tunisia soon. So the third area, so I've covered two, genetic testing and our MENA work, is our work with FQHCs. And this is where I think there's the greatest potential of us replicating some of the things that work well in Michigan and Minnesota. And I'll explain why I'm so optimistic. This is a very well-known FQHC right here. This is the MENA-based FQHC. And MPCA, you have an exact corollary to this called MNASH-C. I don't know how to pronounce it, but it's your community health clinics organization that I spoke with last Monday, and I'll share with you. So one of the evidence-based interventions with FQHCs is we just got our mobile mammogram delivered about a year ago, and we set aside dates for it to park at a few of the FQHCs. We set aside slots for their members. I think we set aside 12 slots per week. And we set up an outreach program, which I'll talk a little bit about. And we had pretty good success filling those 11 or 12 slots every week. We screened almost 1,500 folks and only a 12% no-show rate, which I'm told is very good for these mammograms. So the FQHC work in general was around cancer screening catch-up. So a lot of it is still the remnant of COVID, but some of it was existing before COVID. There were still a few areas where they were not up to their universal health indicators, which is their HEDIS measures in FQHC land. So we had set up 3 quality control interventions to close the gap. And it included us training their community health workers every FQHC in Michigan has at least one, and in some cases up to 20 community health workers. So we train them how to do motivational interviewing just around social determinants of health, which was what they wanted to learn about, and cancer screening catch-up. So we did that training about 5 times, covering over 100 CHWs. And then Larry Ahn, who was here, we stole him from you. He's now at Michigan. He's an internist with an interest in health communication. He's built an app that assists the CHWs. It assigns people who are not up to date from their medical record, and it gives them tips of how to start a conversation about someone and how to even schedule their cancer screening catch-up. And these are the same CHWs who also learn motivational interviewing, so they have an app to support their MI counseling. So last week, I ran the first of these trainings. So right when I got here in February, ACS reached out and said, oh, someone who you work with in the Michigan, the Valley region, I forgot the exact name of it, it's 3 states or so, said, oh, you had a great program in Michigan, would you be willing to start it up here? So the first thing we did was offer for, again, it's Monash CA or something, I can't pronounce it. They helped with ACS to sponsor. We invited people from 15 different FQHCs around the state of Minnesota. We filled up all 25 chairs, and we've committed to doing 2 more. We're going to do one up north and one sort of northwest, so people don't have to drive too far. And it was pretty successful, and we hope the next step will be to bring Larry on here or do it remotely to talk about how to use the app and how to identify people who are not up to date and how to message them effectively. Finally, I think I'm still on time. This may seem a little odd. So this part of my presentation sometimes gets smirks and people say, why are you doing this? But bear with me. So I met a colleague at the university, Yatrik Shah, who's a basic scientist and one of the co-leaders of the basic science biology program. And he had started to look at developing mouse models for understanding social deprivation and risk of colon cancer. Then we brought in a pediatric oncologist, Erica Newman, who happened to have the same interest, except she studies neuroblastoma. So I'm going to talk about her work first in neuroblastoma, because she's now jumped ahead of us. And then our work on social determinants in mouse models of colon cancer. So she self-funded a study looking at food insecurity in mice and whether or not they developed neuroblastoma, how big their tumors were, and how spread they were. And the technology is beyond me, but I know enough to be moderately informative. They take cells and inject it into the adrenal gland of the mice. And it pretty much then guarantees they're going to get neuroblastoma. And then they expose them to the food insecurity stress and normal feeding. And then they had a period of washout, and then they tracked them until they sacrificed the mice and looked at their tumors. So they had injected them with cells that are almost guaranteeing that there'll be neuroblastoma. And then they looked at, then they exposed them to this underfeeding, overfeeding module. This is sort of a standard protocol that people use for mice models of food insecurity. And then what they found was tumor volume in the food insecurity condition was greater, significantly so, and tumor weight was greater in the food insecurity condition, as were corticosteroids greater in the food insecurity condition. So based upon that pilot data, we submitted an R01 and last July, and it got a fundable score, and she's still in the process of getting her award notice, and her fingers are crossed. It is swept up in the health disparities cancellation movement. I've had 3 of my grants have been terminated. 1 has been reinstated, 2 have not, because they had health disparities in there, and they confused. And there's an editorial in this month's American Journal of Public Health where I copied my letters, and it's a very sarcastic editorial criticizing the head of NIH, so that's the end of my career. They canceled disparities grants because the word equity occurs in DEI has the word equity, health disparities and health equity have the word equity, and they literally are defunding health equity research because it shares the word equity. That is actually the reason. And the letter states it, that health equity research fits into the illegal DEI category. Anyway, I believe she'll get funded at some point, and this will allow us to look at not just the stressor of food insecurity, but some other stressors as well. So although our work preceded her, we're so happy for Erica. This is our work with Yachuk Shah and one of his postdocs. And basically, the first paper that we have in this area just manipulated enriched environment versus impoverished environment. And that was the social deprivation for the mice. And what we see, very similar to the neuroblastoma data, this is now colon cancer tumors, is both tumor number and tumor volume were significantly higher in the impoverished, which he calls unenriched environment, when the mice were exposed to no place to hide, no place to snuggle, and no social interactions. So we have an R21 that just missed getting funded. So we have to put it back in again. But we extended the work to include 3 social stressors. Learned helplessness, where when they start, if they press the bar, they get an effect on loud noises and other things, and then that bar gets turned off, and so at some point they get a sense of futility, not necessarily psychologically, but behaviorally they become futile and they stop pressing the bar. And then there's social defeat, which is a little bit of a cruel condition where larger, more hostile mice are put into their cage, and they don't kill them, but they do bully them. And they go through several weeks of this bullying with a larger mouse. And we think these have human analog. This is where people smirk. So we specifically chose these 3 things, and the third one being the condition we tested previously in our self-funded pilot of impoverished environment. We think these 3 have a human analog, and there's a paragraph in the grant for each of those. What is the human analog to these 3 stressors? What's cool about being involved with basic scientists is Yachuk also is going to measure their immune function and also going to measure their microbiome as mediators, as the biologic pathway through which the colon cancer may be spread. So it's very complicated. So there's 2 ways to encourage the mouse to get colon cancer. One is a chemical irritation, and one is a genetic knockout that is stimulated through tamoxifen, way over my pay grade. But these are the 3 manipulations here: social defeat, impoverished, and learned helplessness. And then we'll look at tumor volume and tumor spread. So this slide is now obsolete because PED, at least for now, is no longer in its old form. But this is just an example of our cross-program collaboration. You've seen several examples of it today. One of the things that we borrowed this from another cancer center. And again, when they did it, they got very strong positive feedback from their EAB and their CCSG site visits, so we replicated it. We offered to the community grants that they are the PI. This is not where the university folks go and reach to collaborate with the community agency. This is the community agency submitting as the PI. They could get up to $50,000 for 2 years. We awarded 4 of them. They each have a different community of focus. So one is in MENA, one is in Native Americans, one is African Americans, one is for Asian American women. Different outcomes: screening, smoking, and screening. And one of the things that worked very well, these are almost done now, they're about 3/4 done, is we supported them by helping them choose their measures. We gave them statistical support, and if they wanted help with intervention ideas, we were there. So this is a really strong partnership where the community is in the foreground and we're sort of in the background there to support them. All right. That is, I try to leave room for questions.
I have microphones for questions.
Ken, thanks for the talk. So I mean, the mouse models are obviously really interesting. Have you looked at, or do you have any focus on what immune component between the impoverished environment or anything else? Do we know, is it adaptive immunity, innate immunity, inflammatory, suppressive? You know, I think if you continue this, I think a lot of people would be interested in having a discussion about that. And you and I discussed the intersection of this, you know, with cardiac health and all kinds of things that
Yep.
would be important. So do you know anything more about the
Yeah, so
immunologic factors?
So first of all, they're measuring cortisol as like an indirect measure of immunosuppression, I guess. But they were going to measure T cell, I think a functional test where they take the cells out and expose them to things. And I think it was going to count killer cells as well. And again, there's a whole 2 paragraphs that I haven't read in about a year, but it talks about what the assays are and what functional tests will they be looking at. Good. Done.
So, I just sort of crazy idea flashed into my head when you were talking about the stress and cancer. The group at Penn started so mammary cancer in companion animals in the United States is almost unseen because of practices of spaying early. So there's no hormonal influence.
Right.
But there are animals in shelters that have not received veterinary care throughout their lives. And so the group at Penn sort of exploited that and started a breast cancer, mammary cancer clinic in aged dogs in shelters. And it just dawned on me that with the relationships that the vet school has with Minnesota Humane and other places, you might actually be able to do real world data to understand social deprivation in cancer incidence in companion animals. And I think there's besides our group at the vet school, there's a group that basically deals with the there's a shelter medicine group. And I think it would make for a really interesting discussion to look at sort of that health disparity as a model. And if you're interested, just touch base and we can set up a meeting and discuss.
Very cool. My first reaction is it would be interesting to look at those animals who do not get adopted or do not get a purpose to see if their risk, controlling for the fact of their other background data, to see if being adopted lowers their risk. It's not exactly what you were talking about, but that would be exciting.
Well, it's an opportunity.
Yeah. I could see some really nice natural experiments.
So I had a couple really nice talk and interesting work across a whole spectrum of things. I had 2 just comments and then a question for you. So on the angry mice, for example, I think like Jeff was mentioning, Dr. Zerdoki in pharmacy here has a mouse model looking at that for chronic health conditions in the equivalent of cancer survivors. And how we actually see cardiac toxicity for that. I don't know, Jeff, if they've looked at the immune system, but it may be something we have to ask him about it. And Lena Clark, who's at Hormel, is somebody else to think about connecting with, who has some animal models looking at kind of similar questions of what you're asking in cancer development as well as chronic health conditions. So I had a question on the flip side about how you did the consumer survey, looking at your COE, just thinking about right now, as you know, there's also a lot of ongoings about Masonic and the university and the state. So I just wonder how you did that and think it might be interesting.
Yeah, and I don't know if this is the best time to get up a consumer rating of Fairview of M, maybe when the fires hopefully die down. But basically, we gave a weighted sample schema to Harris Polling where we oversampled in Southeast where we're physically located, but we also got enough people throughout the state that we could have adequate precision. Every major healthcare system's on the list. It's 10 million people, but there's only like 15 healthcare systems in all of Michigan. So the list, both in 11 and 19, included every healthcare system. And we did some focus groups to get the items. So we asked people, how do you view Michigan and cancer centers and Hermanos? And that generated those items that I flashed 3 of them on the screen. So Again, I think it would be really fascinating to do it here. It was about $48,000. It actually could be an allowable expense in CCSG. They don't consider it violating some of the terms. But anyway, I think you'd get a lot of bang for the buck to look at how consumers look at us versus Mayo and us versus Alina and Health Partners. It would be fascinating, particularly around cancer. Although to help pay for it, Jeff, we could add some cardiovascular items and see if they would buy some items. We could add different orthopedic surgery and see if they want to buy some items. So that's how we help pay for it. We had some co-sponsors who weren't cancer focused. Doug?
Yeah, so this is actually a follow-up question to Ann's. And the question is, how do you think you improve the ratings over time in terms of favorability? And I'm gonna put this in context as a University of Michigan alum, and I just spent a week in Ann Arbor with a friend of mine who's having cardiac surgery, but I couldn't help but notice there was a lot of mass media, Michigan medicine on TV.
Yeah.
And since you brought up Mayo, obviously Mayo does this a lot too. You
Yeah.
can't turn on the TV without seeing a Mayo. It's not necessarily cancer related. It's just, this is a fabulous place
Yeah.
and you should come here. So how much do you think mass media or even social media drives the favorability ratings?
So I think a lot of it, and MD Anderson buys national airtime too, and so does the Harvard. I'm just having a senior moment. Dana-Farber does national advertising. There's actually, being a health communications researcher, there's technology to look at that. So there is exposure data you collect. How many ads did you see? I know it's imprecise, but it works, that we're advertising for Mayo Clinic. How many ads have you seen? And then you correlate that with their attitude outcomes. So if we got serious, we would try to control for media exposure through these techniques and then hopefully give an empirical answer that it's advertising that's driving it. I like to think it was the fact that we worked in 50 African-American churches. I didn't talk about that just because I wanted lots of time for questions, maybe too much, sorry. We did a lot of cancer prevention in Black churches throughout Michigan. And I think that may have helped in addition to the advertising.
Okay, I think I'm next. Yeah. Okay. Great talk. I was really interested in the work that you presented on the FQHC and the community health worker motivational interviewing. And I was curious if you could comment a little bit on what you see as next steps with that. Specifically, you know, what you're hearing, or what you did hear based on that, just in the context of some of the interviewing that happened in terms of the needs of the workers, where there's opportunities out in our broader catchment area.
So I think we should, and Renee Garcia is the woman from Menashe who's been organizing this. She's very hungry for what I'm about to describe, is to help identify people who are not screened. Some of the FQHCs already have that through their EHR, some less so, but then develop tailored messaging that we would help them deliver through. If it's Epic, there's technology inside Epic, you can do it, but if it's a lesser EHR, we could do it externally. So they would get motivational messages tailored to what we know about their health. So the last time they had a colonoscopy, for example, you had one in 2011. So we would try to incorporate that into the messaging and then build what we did in Michigan. It's not hard to do it here. The combination of CHWs in the app, they get a roster, let's say 5 people, something modest like that. And they're assigned trying to get those 5 people to schedule a mammogram, pap smear, and maybe a lung cancer low-dose CT test. So I'd love to work with them and you guys to start a pilot in 1 or 2 FQHCs. And if it works and there's enthusiasm, go statewide with that. And we could do it without a lot of, I mean, of course, we'll look for a grant, maybe an R21 or something, but we don't need hundreds of thousands to do that.
I wanted to follow up on Doug's question. And so I think we all know that the most effective part of the Mayo and St. Jude's and other health systems is their PR departments. But I'm curious, you know, if you think about starting a campaign, if you've ever heard of the Duracell bunny.
I have.
You know, and so people have a perception of something and they see an ad and that perception becomes a reality. So, you know, they see the bunny and they know Duracell batteries and they connect those two as opposed to the Energizer bunny, it's the Duracell bunny. So I wonder if you start an M Health campaign as a communications professional, how do you differentiate that from Mayo?
Yeah.
They both start with an M, right? And they're both in Minnesota. So I think there's a, yeah, so does Michigan, yeah. So I wonder if you have some idea if there's any research in how to overcome these these tremendous biases that the consumer already has.
So being married to the president, it does give me one advantage is I get inside dope about our next branding campaign. The university, Chris Gotti's group here is about to launch an entire new brand. So the Discover is going to be replaced with something else. They're finalizing the exact wording, but Michigan had a very good one, which is there's an answer and there's a Michigan answer. That's their latest one. And I do think folks will like the new Minnesota one, and I hope it'll allow us to differentiate from Mayo. But it could be even before the end of this year.
One more comment on some of the environmental factors. I think one thing that's really been interesting to the Center for Immunology folks is how bred mice in a research lab is very different from,
Yeah.
you know, this whole concept of the dirty mouse. And maybe think about the, you know, the environmental social things that go on in a pet store.
Yeah.
Versus children who want mice for pets and all those other things. So I wonder if there's really a linkage, you know, with food deprivation. I haven't really thought about it, but maybe you can make some distinction on immunologic microbiome, free mouse versus red mouse, and tie it into some.
Yeah, that's another natural experiment where they can measure a cross section of laboratory versus retail mice and look at their killer cells and their T cell function and capability, and then track them over time. Yeah.
All right, we've got one question from our virtual group from Masato Yamamoto. How was the relationship between stress and calorie intake or food consumption in your animal model?
So in the Newman study of neuroblastoma, the stress is the food insecurity. So in the colon cancer version, it's a background variable, it's a covariate. But in the neuroblastoma studies, it is the main independent variable that's being manipulated, where they basically are given less than they need, then as much as they need, and then more than they need in a sequence that is established. So there are other confounds because it could affect their body weight. So one of the criticisms we were most worried about is how do you adjust to the fact that weight and leanness might be the actual determinant, not food insecurity. You've banked on the idea that you're creating stress by underfeeding them. Well, maybe it's you're just making them fatter or leaner, and that's it. So we have to do some pretty good statistical controls for their body mass index to try to tease out the food insecurity stress from the change in weight.
All right, are there any other questions? Let's say thank you one more time to Dr. Resnicow.
Thank you.